Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Professor, Doctor, and colleagues. Yeah, this afternoon we have a special lecture. Yeah, from Professor Dr. Bahman Franz Heinrich. Yeah, Heinrich. I'm sorry for my pronunciation. The topic quite interesting because we always curiosity about the what must have been looking when we do the ultrasound. Yeah, the topic is the basic ultrasonography on fetal diagnosis. And after the Prof. Bahman give a lecture, we will discuss, Prof. Yeah. And the topic will delivered in 40 minutes. It's okay. 45. Okay. So we can 1 hours 15 minutes to discuss. Yeah. Please, Dr. Prof.
So thank you very much for this invitation here to be here in Indonesia, especially in Yogyakarta. So it's the second time I stay here, but I enjoy it very, and I love this friendly people in Yogyakarta. So it's very nice experience for me. So the Germans are a little bit stronger, but so I learn a little bit to be more free, and so that's very nice. So I should start my lecture, okay? So I have to check. So I cannot. So I hope you can all hear me, and I would like to start my lecture. I hope it's not too long, but I make some ideas what is important for you to learn. And I think that the resolution in the last years have improved more and more, and it's very important that we have better resolution in the machines. We have better experience in our knowledge about the fetal physiology and development. And that is the reason why we have learned more and more in the last years about the fetal development in the pathophysiology and also for the physiology. And we start for making ultrasound and try to make such nice images for in the first trimester where we see the profile at 12 weeks or later for showing the fetal cardiac examination. And we can see here the aortic arch. It's also important to get some information about the hemodynamic with Doppler sonography. On the other side, it's not only the fetus. We have also looked for the maternal problems to avoid prematurity or bleedings, and this is the case with placenta previa accreta also in the front. And new things with 3D sonography. So it's we can discuss later, toys for boys, or is it really helpful? So this was an image in the 16th on the left side, and that was published in the Lancet in 175, and this was shown in spina, and also it should be in spina bifida. But we are all sure it's difficult to detect with the knowledge from today. But we look today, 2021, we see details in the fetal spine, so we can detect also the conus medullaris in the spine, and so we can rule out spina bifida especially. So there was great development, and Stuart Campbell has for 15 years said, okay, it's not possible that we detect closer than 1 centimeter. Now we are in millimeter areas. You should, it's better, okay. Okay, it's better now? Okay, so the resolution will be increased in the last year with high frequent transducers, also with electronic matrix ultrasound, with color Doppler sonography. We have also high frequent transducers with transvaginal ultrasound, and we also introduced volume sonography with 3D, and we can make very thin planes to detect all the structures in the fetal brain, perhaps, or also in the abdomen and so on. So this was a development. This was started by Ian Donald, published in Lancet, 1948. And this is a development over the years. So we have a very high increase in resolution, and also not in 2D, also for 3D examination. And these are the newest images that we can detect with ultrasound, that we can make with ultrasound. These are fetuses or embryos around about 9 to 10 weeks. Yeah? But it shows nice images, but gives us new information for our routine, clinical routine question. So these are the probes we are used, and in normal case we use the curved array probe, and we have also a linear probes that was more for the for the breast analysis, and we have also transvaginal probes. They have the advantage for higher resolution, and for volume sonography we get the other probes. So we can get some volumes, and then we can analyze this volume block. So what is important? The most of us try to take the transducer and look for the image, but we have to do and make the image. Yeah, and there are some ideas that we said, okay, we used our transducer for sliding, rotation, changing the angle, press also a little bit more and not so much, and combined all this movement. And this is important to make a good image during this ultrasound examination. So as we start, this is a beginning, and this is a very important period in the early pregnancy, because we have to calculate the crown length, the length of the baby, and in this age we have the possibility to estimate very exactly the gestational age, and this is important for a lot of other things, to calculate the management for IUGR, for macrosomia, for prostate pregnancies. And we can combine these measurements also with the biparietal diameter early in pregnancy. So we have a good chance to have a clear period of around about 5 days to calculate very exactly the gestational age. So this is a video clip that shows very early the intact viability of the baby with transvaginal ultrasound. And in early pregnancy, it's important to say, okay, where is the embryo located? Is it ectopic or not? This is clearly not ectopic. The number of embryos we have to document it, the dating of gestational age, and so we can rule out missed abortion, incomplete abortion, or also gestational trophoblastic diseases. And the aim is that we can avoid in some severe diseases, severe hemorrhage, shock sepsis, or maternal death. Also, we have a clear intrauterine detection of this pregnancy. So what are the criteria in older pregnant age of gestation? There are some guidelines from the ISOC. So it's a very good society with good guidelines. And they show that we have to, at first, to calculate the gestational age and look for a very good growth of the baby, to calculate the cephalic, the abdominal, and the femoral length measurement. And there are very good planes that was standardized, and we can go in details, but you see that it's very important to have a very clear parallel and symmetric visualization of the fetal head with the structures of the thalamus and also the cavum, septum, pellucidity. We have also in the abdominal a symmetrical plane that's very important to show the stomach and also the sinus venous, the portal sinus, and have a clear view of the femoral and measured from the diaphysis to the other diaphysis. This is a measurement where we have to do. We can measure outer, inner size of the biparietal diameter, but also there are some norm curves that measure outer. So you have to look very intensively what is your norm curves, what are your reference ranges, and then you can take it. But it's important to make the same measurement and to compare to your reference ranges. So in our country, we do outer measurements with circumference or by biparietal or fronto-occipital measurement. The same was done by the abdominal measurement. We measure outer and try to make a very clear symmetrical plane in the abdomen. And by the femur, also important to measure only the diaphysis from the ends of this bone. So, but this is not the only one. We have to look also for the amniotic fluid. We see here one example. We have placenta that looks nice and normal, but we have a sign of oligo or anhydramnion. That is a sign where we have to detect or to look what is happening there. Are there kidneys from the baby missed, or is there leakage of the membranes? On the other hand, we have the polyhydramnios, and therefore we have also look for the cause of this polyhydramnios, especially in twins or in singletons. Could be a congenital diaphragmatic hernia or some disorders in the abdomen. So this is also a very important thing to evaluate a very good pregnancy, to look for the cervix. We can do it also with abdomen, with a full bladder, but the best images we can detect by transvaginal sound. So I'm not sure how often it's performed in these countries, but we do it in Germany very often, and makes from the inner to the outer length of the cervix. We have a shortening cervix. We can see that there was a triangle, and by progression of this cervical insufficiency, we can see that it's at first shortening, but it could make also a U shape. And on the other hand, we have a prolapse that was very high risk for prematurity or for getting a birth as soon as possible. So on the other hand, we have a look also for low-lying placentas. That could be a reason for hemorrhage. We know this all. And we have this at 20 weeks. We have a good chance that the placenta is growing up because of the growing of the uterus. On the other hand, if we have a placenta previa totalis, then we have no chance for getting natural birth. And this pregnancy or this pregnant women have a high risk for bleedings. And so it's very important to manage her very closely and send her also in some specialized centers. This is only done by the delivery is then done by C-section. On the other hand, we have also the possibility to evaluate the placenta. You have seen the normal size, and here are some examples for trophoblastic diseases. We can see also by Turner syndrome. We have also in twins different echogeneity. We see in the donor more lighted placenta was thicker, and by the receptors it's more, the texture is more dark. And also we have in hydrops placentas, it's very large. And that's the reason why we have some pathologic situation, and we have to look very careful what's happening there. So on the other hand, we have also abnormal invasive placentation, and we have an increased rate over the world. And I heard yesterday that every week you have a case of placenta accreta, and this was a new name, PAS, placenta accreta syndrome. And we know that by increasing the number of C-sections, the risk of developing such an very severe complication is very high. So detection is very early, is very important. And these are some images that shows that we have a conspicuous Lacuna formation. This is very suspicious for placenta accreta. We have also see that there is no separation between the placenta and the myometrium. We see a bulging of the placenta within the urinary bladder. I'm sorry, it works not by the internet. See here the bulging, and where for vascularity in the placenta was show that we have a bridging of all the work. No? Okay. We can do it also by 3D ultrasound, but I think toys for boys or make it more information. So, but so it make fun, and we can try to make some interested new pictures, and we have to decide if it's helpful or not. But to my mind, we should concentrate to the other situations we see in the above images, and also for the vascularity. And this is the reason why we have to look very careful, because we know that there's a high risk of getting the patient some transfusion, blood transfusions. He can get more infections. We have a higher risk for defects of the ureter, of bladder, and so on, and also for emergency hysterectomies. And we should avoid this. And we know all these images, we can very good prepare this patient for an optimal perinatal management. So we can reduce blood transfusion, we can reduce all these complications if we have a good management. So ultrasound is very important, and to get all the nice images also. This is a development over the last years. So in the 18th century, okay, we have only our fingers, we have our history, that is good, but we don't have a chance to look within the uterus. And by the introduction of cardiotopography, the first ultrasound, make more documents for the passport for pregnancies for the women. That's important. All the data were documented in this passport. And the modern delivery rooms, so the patient have not so much anxious. And now, in the 9, 20, 30 years, it starts fetus as a patient. So what is happening that? Yeah. So we have the chance to get diagnosis and try to treat the fetus inside. But the first thing is that we try to optimize perinatal management. And this leads to an extremely decrease in perinatal mortality and morbidity, both for the mother as well as for the fetus. These are some historic overviews that shows Ian Donald with his first publication, the first intraperitoneal blood transfusion that was made by rhesus incompatibility. The first treatment was antenatal maturation of the lung with Celstan by Sir Graham Liggins, started in Australia. And the first intrauterine transfusion when in case of fetal anemia, thrombocytes, hyperimmune globulin, stem cell therapy. So we have a lot of chances to do this now because we have good ultrasound images, have small needles to have the way to the fetus. Then the next step was, okay, diagnosis was one thing, but can we treat? And in San Francisco, Philadelphia, Nashville, there was the first center that start with a very big fetal surgery by laparotomy. Today, it's more in the direction that we make laparoscopic therapies. And the very good one is one that introduced by Julian Delia with the fetoscopic laser therapy in twin transfusion syndrome. And also that was modified by the Eurofetus group that was at first the leader, Jan de Brest and Nicolaides and Gratakos and so on. So why should we make ultrasound in detail? We find 2 to 3% of all pregnancies will be affected by congenital abnormality. And this is very important, only 2 to 3, but these cases are very important to have a good management for mother and also for the fetus. And therefore, it's also important to make a very good counseling for the parents with regard of the birth. So we would like to avoid unnecessary C-section, and we would like to optimize the route of birth. And we would like to optimize also delivery with this healthy fetuses in best centers for excellence to have a good survival rate. Or in severe cases, we decide also termination of pregnancies. We have to discuss it very in detail with the parents and also with our ethic committee. So Nicolaides was one of the pioneers, said, okay, we have to do ultrasound early as possible in pregnancy. So he started the concept that we have very detailed analysis of between 11 and 13 weeks of gestation and look for, at first, chromosomal abnormalities, for structural malformations, multiple pregnancies, early detection of preeclampsia, IUGR, full-term birth risk, and diabetes, and also for abnormal placentation with the aim to improve and optimize perinatal management. And they introduced the diagnosis or the evaluation of the fetal nuchal translucency. Yeah. And at first, these are very good images. We start for 10 years ago. And we see at 12 plus 5 weeks, the brain of these early fetuses with the plexus choreoideus. We see also the abdomen with the stomach. We see also the bladder. So we can rule out a lot of malformations in this early age of gestation. We can also detect the both umbilical arteries besides the bladder. We can evaluate the femur, the spine, especially the kidneys, and we can see also the abnormal umbilical cord insertion to the placenta. So we have to look, and if we have ideas what we can detect, we should do this. And this is the focus on my talk, because this is the development in the next 10 years that we evaluate as soon as possible. So what should we detect in this early age of pregnancy? This was a nuchal translucency, this fluid in the neck, and also the nasal bone we can detect. And if we see this, we reduce the risk of trisomies very high. And but it's difficult. Of course, we have to magnify. I'll show you later. And we have values that was around about 1 to 3 millimeters. So that is the resolution today. No? And we have to magnify, we have to improve all our images to detect and to evaluate all the structures. We can see also within the brain with structures and But if we start, we should magnify at first the first trimester to evaluate the nuclear translucency. The next step is that we reduce our gain. There's a black and white, so we should reduce so we can detect the fluid that was dark, that was easier. Oops, sorry. And then we have a good magnification and good depiction of this sagittal plane. Then we make an inner measurement with the largest distance. That was the IT, or nuclear translucency. So these are some videos that shows that was the best position, but baby is not every time in this good position. So we have to change. And it's time consuming to have a very good resolution. But you see, there was an organal plane that we can detect also the fluid within the fetal neck. And this was in view, you said it's normal, no? So, babies. This is another view. You see on the left side, starting, also the best plane for evaluate the nuclear translucency. We can see also the inner part of the brain with the cisterna magna, with the stem brain. We can see the maxilla and also the nasal bone. But on the left side, we see rapidly increased nuclear translucency. So what should we do now? What would you like to counsel this patient? We know that here is a higher risk of problems. This was higher risk if the nuclear translucency is increasing, then we have a higher risk for an aneuploidy with chromosomal abnormalities, with intrauterine death, also for structural anomalies. But we have to look very careful because we have the risk that also, or the chance that also there are some healthy babies in case of increased nuclear translucencies. No? So that's our aim, to detect very early, and it's only the chance that we, how to do this, we make invasive procedure like amniocentesis or chorionic villus sampling. So, and these are also a good publication that shows in an experienced hands, we have a very low risk of or embryonic loss. That was round about 0.2 in both procedures for chorionic villus sampling as well as in the amniocentesis. We do the chorionic villus sampling between 11 and 14 weeks. And after 16 weeks, better 16 weeks, we perform the amniocentesis. For the genetic collects, it's easier to analyze the amniotic fluid because it's safer for the growing of the cells. On the other hand, we have chance to reduce the morbidity also for amniocentesis procedures and chorionic villus sampling to introduce the C3 DNA analysis. We can do this in many patients and pregnant patients. And this study shows that we have a high sensitivity that was 99% roundabout for detection trisomy 21. But if we have this risk, we have to make also an amniocentesis to check it if this diagnosis was right. And if we do only the first trimester screening, we have around about 80% sensitivity. So, but it makes a lot of controversy and discussion in the society. I think that's worldwide. So now, what is happening with the structural anomalies in the first trimester screening? We have a detection rate in low risk groups for around about 30%. In high risk groups is more than 60%, especially for parents who are more older than 35 years. But we need standardized examination protocols, good anatomic planes, the expertise in embryology and good ultrasound probes that we have a good machine. And these are images, you know this, but here is the anencephaly. We see an alveolar holoprosencephaly with loss of the cortex and a big thalamus. And we see also an encephalocele. These three have a very worse outcome. So we have to decide what should we counsel this patient. And this baby have no chance of life later after birth. So on the other hand, we have also the abdomen. That was a normal abdomen. That was a normal view, but we see also in the early pregnancy these signs of a baby that was near the placenta, no movements, and we have no structures that we can depict. And this is an example for a body stalk anomaly. On the other hand, we have a baby that is moving and was not in very sharp limit to the other structures. That was a typical image for gastroschisis. And then the other thing that there was also a severe abdominal defect that was an omphalocele. But the prognosis of this baby is very bad. It's not alive. Or could not alive. Gastroschisis have a very good prognosis. They have no higher risk for chromosomal abnormalities, but we should make a very further detailed analysis of the anatomic structures. And the difference to omphalocele is that this baby has a higher risk for chromosomal abnormalities, especially trisomy 21 and trisomy 18. So we have to rule out or we have to evaluate the karyotype of these babies. And then if the baby is fine, has a good prognosis. We have here also a few cases that was an hand deformity very early. Case was trisomy 18, not good prognosis. We have an hypoplastic left heart syndrome at 12 weeks detected. And we have also some cases that was typical example for a LUTO, low urogenital obstruction. And so we have decided, can we do an vesicoamniotic shunting in a fetal therapy? Is it necessary? Is it make it sense? So we have ruled out also the chromosomes because in this case, the baby has a higher risk for chromosomal abnormalities, around about 1/3 of cases. And then we discuss the situation for vesicoamniotic shunting. It should be very strange discussion with the parents. This baby have no chance for a life after birth, and this baby have to send in a special center for delivery, so the baby have also a good chance. On the other hand, twins, also some problems with conjoined twins. Therefore, it could make sense for 3D ultrasound. And we have also an example for the twin reverse arterial perfusion. This baby was not well developed, have an acranius acephalus. We can detect 60% of all malformations in early pregnancy. Yeah, that is the way that we can help a little bit. So when we have not only risk for chromosomal abnormalities, we have also by increased nuchal translucency higher risk of fetal heart defects. And so I would like to show you a few heart images from the fetal echocardiography. We also have the possibility in early age of pregnancies to evaluate the heart, but the heart is like the small finger, the nail of the small finger. It's around about 6 to 7 millimeters. And so that's not easy to detect. We need very good images. This is the older ones. The new ultrasound machines can detect it much better because the resolution is better, and the frame rate is also faster. So that was one. Okay, what is for the basics? Come back to the basics. That's important. How to do fetal echocardiography. It's very important to make segmental evaluation of the fetal heart, to switch your transducer from the abdomen to the head in this direction. And the most important thing is to evaluate, and when you start this examination, to evaluate the fetal heart in the apical view. And this is very important, that you know also the side of the heart, that you can document it. The left side here, you see here the aorta, and before the aorta, there's a left atrium. You see the mitral valve. You see here the ventricle on the left side, and on the other side, the right ventricle. The myometrium is a little bit thicker, and the transcuspid valve is inserted a little bit lower than compared to the mitral valve. This is the right atrium. So we make a test. What is this here? Left or right side? What? Left side, that's right. And it's easy to detect. It's here cut a little bit, but we see here the aorta, and this is the left side. So in this view, we look for the cardiac side, for the rhythm. We look for the size of the left and right atrium of both sides. We look for the function of the valves, but it's not so easy in black and white view. We look for the septum, for the foramen ovale, we see here, and for the pulmonary veins that we see in this direction, not in this good view. So the detection rate, that was a publication that was more than 15 years old, but it's when I was in Norway, I was there for 6 weeks, and they have made a study, and they show that by detection, by evaluation of the 4-chamber view, we have a detection rate of around about 40%. And then there was, they make a further study that they included the 4-chamber view with cardiac outflow tract, and then they can decrease by 60%. So they conclude that teaching, training is a key issue for a better prenatal detection of heart defects. So the ISOC make a lot of courses, and they said in their guidelines that we start at the abdomen. Yeah, look for the sides of the stomach, and then for the heart. You see here also the depiction of the structures. We sweep our probe a little bit, 10% to the upper, to the cranial view, then more. Then we see here's the outflow tract of the aorta, and then we switch 10% more, then we see the pulmonary outflow tract and the 3-vessel view at the end. And if we make this standardization, we have a good chance to detect more than 60%, because the resolution is much better. So in good cases and good trained examiners will reach a detection rate up to 80%. So this is a view that shows the transverse plane. We can start from the abdomen, look for the 4-chamber view, then for the aortic outflow tract and the pulmonary outflow tract. And this is the view. You can start the best if the baby lies in this position with the apical view of the fetal heart. But it's not easy in every case. So we start also in the sagittal plane, where we can see very good the outflow tract, especially for the pulmonary artery, for the pulmonary trunk, and also for the aortic arch. That was black and white, but we start with this to understand the planes So I give you some examples for chamber view that we can see. That's normal. That's the anatomy. And we see an example that was typical for an Epstein anomaly. And on the other hand, we find also an abnormal four-chamber view with an overriding aorta. And these images are 10 years old, so we can see that there was a high improvement in the last 10 years of the resolution. What should we do also when we look for chamber view evaluation? We look for the size and also for the position of the heart. And in this case, we see a right-sided hernia and the left side position of the fetal heart. And this is a typical example for congenital diaphragmatic hernia. Also important for sending this patient to a specialized center, because if this baby died, delivered in a normal hospital without perinatal or NICU, then this baby died. So there's not a good chance, and she has a very good chance for survival, for a good survival, if we detect it prenatally and making good management directly after the birth. Good. Some examples for ventricular septum defect. If we use color Doppler is important to look for the function. No? But we have to reduce our gain, have to look for an optimal pulse repetition frequency like PRF. No? And if we have a good technique for the depiction of the color, then we can see small defects that was around about 2-3 millimeters. This is ventricular septum defect. We can see very clearly and easy the hypoplastic left heart syndrome. It's on the left side, small ventricle on the left side, but it was not filled with color. So it's easy to detect with the color. So I look for the time, sorry. How long I have? 10 minutes or what is it? What, right? Fun? Okay, that's good. So I'm not over. Correct. So next is the function of the ventricles. We see that there was a good function. And on the other hand, we see that the arterioventricular valves are not clearly closed, so there was insufficiency, and we check what is happening there. On the other hand, we look for the rhythm, and we see in this case there was a supraventricular tachycardia, and we have to treat them. Yeah, we have a good chance to treat them with flecainide. It was first option for therapy. And we can detect it by taking an M mode to look what is it. Is it supraventricular tachycardia or paroxysmal? And this was an example for paroxysmal tachycardia. And if we look for the ductus venosus can give us the information of the preload of the fetal heart. And we see, okay, the heart is very the preload is very high because there was a negative flow during the atrial contraction, but it can relax if it's a normal cycle. Yeah, so this baby has a risk for fetal demise, but has also a good chance for a good treatment. So I make the next. Doppler is also very important. So then I'm finished. For making a good diagnosis. And for Doppler sonography, we need a very clear spectrum. So we have to magnify the image, have a good angle of intonation to record all the spectrums, analyze 4 to 6 cycles, and the velocity scale should be 75% of this image. So, and Christian Johann Doppler was started for 200 years ago. He looked for the scars and for the lights and for the reflections and give his thesis there. And the idea for him we have adapted to for the Doppler sonography, and we have a lot of spectrums that we can use to evaluate the status, the hemodynamics within the fetus. So we have a normal situation in the umbilical artery, and the end diastolic that reflects the placental resistance is very important to evaluate in this stage. So we see that there was a loss in the end diastolic flow and also a retrograde flow. Then the baby has a high risk for intrauterine death or for some problems. And we see this changing by brain sparing effect. So the brain opens the vessels, and then we see the end diastolics increasing. And the heart also can adapt a long time. And then the A wave is increased, the pulsatility is increased. And if it's negative, then we know that within 5 to 7 days, this baby could be died. And the reason is in almost these cases that there was some damage to the placenta, especially in case for preeclampsia or patients with bleedings in the early age of pregnancies. We have no chance with to make some therapy like nutrition or application. So we have to manage these patients very clearly so that we have a good chance to optimize. And we know that these very chronic hypoxic babies adapt over the period and adapt with hemodynamics, adapt with biochemical parameters. So we look what is the best size to deliver in this early size. But we know these are only 1% of all patients. Yeah, so it's not so often, but these are the patients that need our help, our knowledge to optimize the management. So I can speak 1 hour more, but I stop now. We are open for discussion. Thank you very much for the attention.
So